All righty, everybody. Good morning. This is John Vilas, your host of From Beacon Hill to the 413. And I'm absolutely ecstatic about the guest that I have with me today. But before we do that, I just want to kind of, for first-time viewers, give a little bit of background on what we're doing here, what this show is all about. A long time ago, I decided to write a op-ed piece with the Westfield Evening News where I basically gave people an update of things that were going on Beacon Hill. And the number of people within the community in Westfield and beyond that kind of approached me at grocery stores and other places, just out in the community, where they mentioned that they really liked that. They liked that update. They liked knowing about what was going on with their elected officials. And I've had multiple conversations with Les on this, and thank you so much for creating this program with Pete, Kenny, and everybody else. And that was kind of the genesis for this show. So the whole idea of this show is to bring Beacon Hill back to Western Massachusetts, talk about a lot of the things that we're doing, and allow the viewers, if they so want, to weigh in with questions, with suggestions, who they want to hear from. So today, again, back to my guest. Up until this point, I've had fellow elected officials. I had my friend, State Representative Mike Finn, who, as we know, because of redistricting, is going to be representing parts of Westfield. Currently, he represents West Springfield and Chicopee. And then, of course, our own state rep here in Westfield, Kelly Pease. But today I wanted to do something different. Today I wanted to bring somebody on to talk about an issue that we have taken up on Beacon Hill and will continue to take up on Beacon Hill, but somebody who what I would call absolutely a subject matter expert. So my guest today is Dr. Peter Freedman, and I'm going to read his background so I don't mess it up. Dr. Freedman is Chief Research Officer at Bay State Health, an Associate Dean for Research at the regional campus of UMass Chan Medical School, Bay State. Dr. Freedman is an addiction physician scientist who has published over 175 peer-reviewed articles on addiction treatment services and outcomes, implementation of evidence-based practices for addictive disorders in medical specialty and correctional settings, and the role of physicians in the care of substance use disorder. He is immediate past president of the Massachusetts Society of Addiction, past president of the Association for Medical Education and Research in Substance Abuse, and former director on the American Board of Addiction Medicine. How about that background? Welcome, Dr. Freedman.
Well, thank you, Senator. It's a pleasure to be here. Thank you for having me.
Absolutely. You know, it's not every day that we get to, I'm a big believer in that we should reach out to the people who are, without a doubt, the subject matter experts in a field. On any number of occasions, I've been involved in legislation where we pass a bill, we do something in the budget, and I'll run into someone who, again, is a subject matter expert, and they will say, hey, you should have thought of this as opposed to that. Right. And did you ever think of the unintended consequences? So it's great to have you. And my goal here is twofold. I want to talk about policy. I want to talk about things that, I constantly ask myself the question of, what are we missing? What are we missing from a policy standpoint involving behavioral health? So there's that. And then my hope also is that there may be someone watching this television show or seeing it when we post it on our social media who is themselves struggling with addiction, or maybe has a family member or a friend who's struggling with substance use disorder, alcohol use disorder, any type of mental health concerns, really behavioral health. And they might hear something that you say today, and it might give them a sliver of hope, we'll say. So I guess the first thing that I want to say and kind of get you to respond to is that one of the things that I know, and we've talked about this at length, both through being intellectually curious, but also my own recovery journey, is that COVID-19, is many things, but it's also a pandemic of isolation. And people haven't been able to converse. People haven't been able to see each other in person. Can you talk about the impact that, in your experience, COVID has had on behavioral health in general?
Well, I mean, COVID, not surprisingly, has had a tremendous impact on all fields of healthcare, and the addiction field is no different. as you know, a lot of work is done in done in groups, meetings, people getting together. A lot of recovery work is sort of interpersonal work, and it relies on that connection between people. And of course, when you're masked, you can't see expressions. That's sort of the one piece of it. But also, when you have a infectious virus going through the community, you've had to socially distance and do a lot of things virtually. So as you probably know, for example, a lot of meetings and AA and other things have really moved into the virtual space. It's happened in all aspects of healthcare, and it's happened in treatment as well. There have been a number of emergency things that have happened as a result of the pandemic that have changed the way we do addiction treatment. So things like greater take-homes for people on methadone and things that sort of reduce the personal contact. And I think the general consensus is it's been sort of a mixed bag in terms of what the long-term impact is going to be on the field. There are some things that I think are very good. The methadone system in particular and our how we do medication treatment is very restrictive in general. And so I think a lot of the innovations in that area as a result of the pandemic will end up being good. But in terms of the recovery work and the interpersonal work, that has really been very challenging for the treatment community. And then sort of as you alluded to in your introduction, on a personal level, it's a very isolating. During the pandemic, people were very much isolated and on their own. We've seen across the country an almost 40% increase in opioid-related overdose deaths. It's interesting, the total number of overdoses, there may not be much different, but the lethality of them is. And I think a lot of that is because people are using alone. And if anyone out there is, suffering from the disease of opiate use disorder, using alone is one of the major risk factors for folks having a fatal overdose, because there's nobody there to institute reversal, the reversal agent, naloxone or Narcan. So a lot of those things have happened. Interesting, in our state, we have seen an increase in overdoses during the pandemic. Not as much as in some other states, because I think we've been fairly aggressive, and there have been a lot of programs and initiatives to really try to reach out to folks who are using. But still, we've seen, year over year, a 5% increase from 2019 to 2020, a 5% increase. This was after a couple of years in which we'd started to see a decrease. So yeah, the pandemic has. We have stepped back a little bit from some of our gains, and I think many of us are hopeful that, going forward, as hopefully Omicron is gone and the pandemic starts to wane, that we'll be able to get back to seeing better outcomes for our patients.
You brought a lot to unpack with what you just said, Doctor. But one of the things you mentioned, if there is that person back home who sees this, and you mentioned how dangerous really it is when folks use alone. And I'd be remiss if I also didn't say that we also have something called the Good Samaritan law, where you would be legally immunized, we'll say, if you were to call the police, if someone were to overdose, the police were to show up on the scene. Because of the Good Samaritan law, you will not be prosecuted for heroin being present or really any substance. So that's just a really important point, and that's one of the main reasons having you to kind of talk about the boots on the ground, if you will, that real world lived experience. You mentioned something that I really wanted to get into, and you talked about methadone and medication-assisted treatment. And in anticipation of this today, I was doing some research last night, and I just want to read you this quote, and it's Of course, I don't have the person's name, but it's from someone like yourself, another foremost authority. And the quote is, "The research is clear. Medications for opiate addiction, MAT, are very effective. They cut mortality and rate by half. They keep people in treatment. Yet in the U.S., the majority of addiction treatment facilities don't yet offer these medications. Only 42%, according to this author in that." If you, and we've talked about this before, my approach to recovery, whether it's you're someone who believes in an abstinence-based program like the 12 steps, medication, you referenced methadone, cognitive behavioral therapy, or all of the above, which is something that works for a lot of people. When something is so effective, like medication-assisted treatment, methadone, Suboxone, Vivitrol, why isn't it more readily accessible?
Great question. So I want to start my answer by sort of clarifying that, there is a role for sort of recovery and abstinence-based counseling in the care of people with various substance use disorders. But the extent to which that is the primary treatment versus medication varies based on the disorder. And the way I like to think about this is if we were talking about cancers, right? There are different types of cancers. There are blood cancers. There is brain cancer. There's lung cancer. The treatments that you use, they're all cancer, right? We agree that they're all cancer. They're cells proliferating out of control. But they're different, and the treatments are different, and the effectiveness of the treatments are different. Like for a lot of our blood cancers, particularly in kids, you can have cure rates in the high 90s, percent of 5-year survival from using medications. And whereas for some of our solid tumors like lung cancer, that doesn't quite work quite so well. So I think of substance use disorders along the same way. The way we treat nicotine versus the way we treat alcohol versus the way we treat opiate use have to be different because the effectiveness of our treatments are different. For opiate use disorder, medication is the most effective means of treatment, 100%. And you gave some of the information about that. For alcohol, medications work, but they're not as effective, and you need to do a lot of the counseling and other work to deal with people with severe alcohol use disorder. And then, we have situations like cocaine use disorder or methamphetamine in which we don't have medications, and it's all based on the counseling, and the counseling works, but probably not as well as we would like. We wish we had a good medication for that. So in answer to your question, the medication is the most effective treatment, and there are people out there who extrapolate from their experience. So, and I'll use an example of somebody in recovery from alcohol use disorder who says, I recovered without medications. Why do these people need medications?
That's where I was going next.
And you've probably heard of people like this. And we hear this a lot. The outcome of that is that it tends to stigmatize the medication, and there are a lot of things about the way we do medication in this country that is stigmatizing. So methadone, in particular, is subject to very restrictive rules and regulations that were developed in 1970 based on the way the opiate use problem was in 1970. Much different now, right? Much higher rates of overdose because of fentanyl, and a lot more experience around the world allowing people to use methadone in the office-based setting. The way we do methadone in this country is really needs reform. And so part of the reason I'm here today, Senator, is to ask you to take up that issue, because there are many of us who believe there is a much better way to do methadone. Now, there are federal barriers to doing this. I think you and I have talked about this in the past. Of course, there are federal barriers to legalization of cannabis. We managed to work through that. There are federal barriers to safe consumption sites. which some states have decided to go ahead with, and our state, we'll talk more about that hopefully in a few minutes. But we're at a situation in the epidemic where it is not getting better. In many parts of the country, getting worse. So we need to do more. We need to sort of think about doing things differently. And as you mentioned, a person in recovery yourself, you're familiar with the adage, AA adage. The definition of insanity is doing things the same old way and expecting a different outcome. Yeah. We need to really think differently about how we address the opiate problem. And a lot of that will have to come through policy and legislation.
I love what you just said, and we were having a back and forth, a very open back and forth. I'm saying this to the viewers. I said with the doctor, and I brought up, I did something that I don't like to do often, but I did it, and the doctor called me on it. I attempted to deflect, and I said that this issue with methadone access really is, the impediments really emanate from the federal government. And there certainly is some truth to that, as the doctor said, and it's just the law. But the doctor correctly pointed out about, marijuana, federally, to this day, against the law. Safe consumption sites, federally, against the law. But yet we've moved forward, well, not on safe consumption sites, but certainly on marijuana and some other things. So the notion that we can't do something because the feds have done it is something that I think folks in my line of work here in the Commonwealth might need to be a little more intellectually honest on, myself included.
Well, oftentimes the states will do things and then the feds will follow.
The laboratories of democracy.
Thank you.
Is what many founding fathers referred to it as. That was always the intent. The states were to be the laboratories of democracy. So prior to getting onto policy, so I guess my question would be kind of going back to, because I think, anytime we talk about this topic, my hope is that even if it's one person, themselves or a family member, if there was someone watching this show right now, and there will be, that's struggling with addiction, and again, there will be, what is your first, when that person first walks into your door or you see them on the street, and obviously I know you're going to say, well, it depends on what addiction it is. Drugs, alcohol, eating, fill in the blanks. But let's say it's either an opiate or an alcohol use disorder, and that person's family or that person reaches out to you. What's the first piece of advice that Dr. Freedman gives them?
Well, it depends. No. Well, the first thing I would say to them is, this is a very courageous thing that they do, because as you know, this is a very challenging thing to admit to yourself that it has gotten out of control, that and that you're at the point, I think a lot of people who use substances go along for many years believing, oh no, I got this under control. It's okay, I got it. I can handle this. So getting to the point where you are able to say, maybe I don't have this under control and I really need some help, I think that's really courageous and mature, frankly. I think it's they often talk about an addiction, how it's the mind is infantilized, or you become like an eternal adolescent, not taking responsibility for yourself and your actions to things. For me, it's an act of maturity to say, I need help.
Of course.
So often that would be sort of the first thing that I would speak to somebody about is, what they've thought about, what direction they want to take in terms of their journey into recovery, and then it's our job as treatment professionals and even paraprofessionals, people working, sponsors and others working with folks, is to sort of help them along that journey, because ultimately I'm not the one who's going to be walking this path. Yeah. I often view myself very much like a coach. We were just talking about the Super Bowl before this, but two great coaches, by the way.
Absolutely.
And a lot of the work is sort of helping people find the best in themselves to move forward. So really helping them think about what their strengths are and where their challenges are, and bolstering up the strengths and helping them figure out ways to work around the challenges. That's really the work that I see.
Yeah, no, you raised a lot of great issues there, but the one that kind of sticks out to me is that it's truly, if there was ever a subject matter, in my opinion, that was based on the individual in question, it's this, and what's the best treatment path, we'll say, or what your recovery is, because this is something that folks, a lot of people will come up to me. I'll have a lot of constituents, their family members, that will reach out to me, and my philosophy is pretty simple. The best recovery is the recovery that works for you, whatever you need to do to get there. But one of the things that was kind of a harsh reality for me too is that, and this is my experience, and you may not agree, that until the individual in question, whoever it may be, until they make that decision themselves, hey, this isn't working for me, I can't do this anymore. A lot of times it doesn't work as effectively if they do make that decision. And I'll use myself as the example. On any number of occasions, it was, hey, I want to do this because my girlfriend, she's upset with me right now. Mm-hmm. I'm going to go do this. I'm going to go to this meeting, and maybe she'll back up a little bit. Or I'm going to go talk to someone about my alcoholism or something. And invariably go right back out there. That only, in my experience, again, that only lasts so long. Until I made that decision, I can't do this anymore. So I'd be interested in your response to that. Is there any, do you agree that really, you can offer all the supports in the world, all of them, housing, programs, et cetera, but that person's got to be ready themselves?
Well, what leads people to ready, I think I generally agree, although what leads people to readiness varies greatly. For some people, it is a family member saying, you need to do this, or it's interesting when I was back in doing primary care practice, and I would ask somebody about their marital status, and if they were divorced, it would always trigger me to ask about their substance history. So, there are a lot of impetuses to people saying, oh, I understand this is an issue. So it either can be their own recognition that they've lost control over it and they need to do something about it. But it also may be the consequences. So someone went to jail. We actually have a large study now going on with the jails around the state looking at delivering treatment services to folks in jail. What leads a person to that moment that they realize it varies greatly. I was trained in what's called motivational interviewing, which is a technique to help people sort of resolve the ambivalence around their use. I understand it's a problem, but I can still handle it. And so sometimes it's that interaction with a skilled counselor that brings them to that point, like, oh, okay, I'm ready to do something about this. So there are just like there are many paths to recovery, there are many impetuses, is that a word?
Yeah.
Impetuses or drivers that lead them. What I don't believe, though, is that people need to hit bottom. I think, that is sort of an older philosophy, again, comes out of the 12-step tradition. I don't think you necessarily have to hit bottom, although there are people who do hit bottom, and that's really what it takes for them. But there are many, many people who much earlier in their addiction career come to the realization that, this is something I need to put behind me.
I think that's a really important thing that you just said, Dr. Freedman, because I personally have spoken to any number of folks who will bring up their whatever they're struggling with, and they'll use that adage of, I haven't gotten a drunk driving arrest yet. I haven't killed someone. I haven't overdosed yet. I haven't eaten 17 boxes of Twinkie, whatever it may be, whatever it is. And and they'll use that kind of as a crutch of, I'm not that bad, I can go back out there. And you bring up a great point. Everybody's bottom is different, right? You can get off that elevator when you want to. You don't have to go to the depths of despair. And I think that's a really important
I often say if you're having that conversation with yourself, that's a sign.
Yeah.
I mean, you don't, I'm not that, oh, well, yeah, maybe.
If you're talking about it, it's a lot of what we would affectionately refer to as old timers in some of the recovery movements. They'll look at you and say, "Well, you're asking me about this. I mean, you're not here because everything is going perfectly right now." And so that's funny. That's why I chuckled. One last thing before we go to policy, and this is something I still think this is a debate that's raging anywhere you go. And I think it has any number of implications, and it kind of goes back to the old question of, is addiction a disease? I've heard multiple people opine on this. I feel like you can talk to one person that says absolutely is, and then you can talk to another person. And again, same author. I want to read you a quote and kind of get your response to this, because I think it kind of gets to what many people would think is kind of how this debate is framed. Thinking of addiction as a disease, thinking of addiction only as a disease has the risk of simplifying a very complex interaction of factors, overemphasizing the biological factors at the expense of the myriad social and psychological factors that are also major contributors to addiction. I want you to respond to that, but then there was someone right after who called the author out on this, who said, you are overemphasizing the psychological and social factors to the detriment of the biological factors. Right. To a lay person, what's this debate about?
Yeah, so it's complicated.
Yeah.
The nature of what is a disease sort of speaks to what is a legitimate entity for which physicians and healthcare should be applied, right? If you say that something is a social problem, well, it's not a doctor should not be dealing with that, right? Housing. Now, there are doctors who say housing is important because it affects these other things, but housing policy, although maybe our prior director of HUD would disagree, but so it's about sort of turf and what's appropriate to talk about. It's part of it, and part of it is also sort of the nature of the entity, and is it a legitimate condition? It's a legitimate condition. The way I think about it is very much analogous to the way we think about hypertension, so high blood pressure. So high blood pressure they call it the silent killer, right? It's silent, totally silent. I feel fine. Why? You want me to take a medicine for something I feel totally fine about? It's not affecting me. So I think of addiction or the development of substance use disorder as a continuum between sort of an asymptomatic phase, like your blood pressure, and then a active phase, which acts more like a disease, which we call addiction. So it's analogous to, when your blood pressure causes a stroke, then you're like, oh, or it causes a heart attack, you're like, oh, this is a problem. I need to do something about it, right? So, and we have a lot of entities in medicine like this, right? You take medicine for cholesterol. Is high cholesterol really a problem? Is it really a disease, or is it a risk factor? I'm not sure it really matters. No. It is a legitimate condition for which healthcare solutions are appropriately applied. And the fact that something has economic and social and other implications doesn't change that. If you have a stroke and you can't work, well, that has economic implications too. We don't say, oh, I'm sorry, it's affecting your work, so it's not really a legitimate condition. So it has to do partly with sort of the legitimacy of the condition. And again, some of that harkens back to some issues around stigma for it. And the other problem is it's very challenging to figure out, well, when does it stop being just a risk factor and when does it become the disease of it? And the way I think about that is I think about the four C's, the four C's. You can use the DSM criteria, but you can break them down into what ASAM, the American Society of Addiction Medicine, talks about the four C's. So the compulsive quality of the use, so you feel like you have to each day you get up, you're thinking about it, you're wanting it. The craving, you actually have physical feeling that you want it. The loss of control, which we've talked about just recently, is the third C, that you feel you tell yourself, oh, I'm not going to I'm not going to drink. I'm only going to drink on the weekends, or I'm only, you start to have control issues. And then the consequences and the continued use despite consequences. So you're experiencing adverse things in your life, yet nonetheless, whether it be marital trouble, work issues, drunk driving, other things, yet you continue to use despite having had consequences. So those to me, when you think about when do you have the disease, if you're experiencing those four C's, you probably have a form of the disease. The thing for me that's really interesting about the four C's is because we were talking about medication before, and people often say, oh, medication, you're just substituting one addiction for another, right? We've heard this. And in point of fact, that's not true. That's absolutely not true, because when somebody is on medication, they're no longer craving, they're no longer feeling the compulsion to use, they're no longer feeling the loss of control over their life, right? And what was the last one? And then they're no longer using despite having consequences.
Yeah.
So the criteria that define the disease go away. That's the definition of a treatment, right? The definition of a treatment is you give the treatment and the symptoms, which we talk about as the four C's, go away. That to me is why this whole argument about it being substituting one addiction for another. When we never say to somebody, oh, you're on that blood pressure medicine, you're addicted to that blood pressure medicine, you better stop it, right? We never say it. It's like, but it makes my blood pressure go down. It makes the symptoms of my disease better. It prevents the stroke. Well, we never say that, right? But people feel comfortable saying that about this disorder. I prefer the term disorder.
Yeah.
Because it captures the whole spectrum from sort of it being an asymptomatic, with no symptoms, risk factor, to there actually being full-blown symptoms and affecting people's lives. So that's it. And like the last point, which I think is important about the disease, thinking of it as a disease, is people think of a disease as something you have no control over. So you got cancer, you had no control over it. You experience a heart attack. Well, but you do have control over those things, right? You could have eaten better. You could have stopped smoking. You could, So the notion, it gets into issues of control and issues of like self-responsibility. Like we're often very judgmental about people with addiction. We say, you're responsible. Why should we spend taxpayer dollars on treating people with this disease when it's their own darn fault, right? The people, people don't say that outwardly as much as they did when I started my career. But, you still hear echoes of that in policy arguments. And in point of fact, all the conditions we deal with, we are humans. When somebody goes skiing and breaks their leg, we don't say to them, well, you chose to go skiing, so our insurance, we should not pay for your broken leg. We don't say that. But we feel differently about this disease. And part of this is sort of calling that out and understanding. And the disease model, people worry about the disease. And so that's sort of from the outside community perspective. And then there's the treatment person's perspective, which is if you say something is this disease, a person feels like, oh, well, I have this disease, I can't do anything about it. But that's not true, right? If you have diabetes, you can lose weight, you can go on insulin, you can treat things. So there are things that you can do. So there are aspects of control, responsibility, and helplessness that all sort of go into that discussion that you're talking about.
You just brought up. I could speak with you for days at a time, but
You'll just have to have me back.
yeah, we absolutely will. I mentioned that I had a conversation with Dr. Kelly a couple weeks ago, and you just touched on a couple of things.
John Kelly at MGH.
Yes, sorry, at Mass General Hospital, another guru like Dr. Freedman will say in this area. And one of the things you talked about is in this very topic, and I love what you just said, because essentially my interpretation of it was, on some level, is it really matter? In some levels, I mean, there's something, and I love the definition. The best definition of addiction that I have heard is continued use despite adverse consequences. Very simple, very easy to kind of get your head around. But one of the things that I thought was fascinating from Dr. John Kelly is when he talked about what you just did, where kind of this disease conversation has implications as it relates to stigma. And I know that he was just part of some research that just said, and I think it was from about a year ago, he said, where how we talk about someone in the throes of addiction really, really, really matters. And if you refer to it as a disease, that could be very helpful for evoking sympathy, causing folks to think, well, and this is my words, not his, this person's sick. They have a disease. And he said, but interestingly enough, what their data also shows is that if you refer to it as a disease, there could be some implications for that in terms of getting a job, in workforce issues, in, would you hire this person to babysit your child and stuff like that. So interestingly enough, why I brought that up is his favorite word was disorder as well. It's kind of that neutral, if you will, because there are implications for all of this. And I always thought about stigma just in the context of, hey, if I raise my hand and say that I'm struggling with, substance use disorder or alcohol use disorder, society's going to condemn me. And that certainly is a part of it. But it's bigger than that as well, is one of the things that we had talked about. And I'm really glad you brought that up. But I thought that was brilliant how you just kind of talked about the spectrum. And, someone presents this way, and then towards the end of it, a very different way. That was great. And I agree with that. I mean, if someone is struggling, let's just try to help them in whatever path that looks like. And let's care less about the labels and more just about what are you presenting with and how can we help make you better.
Yeah, I agree with you, although the labels are important because, so for example, healthcare providers need to put a diagnosis in the medical chart, and that label is what allows them to get paid. And although as a healthcare provider myself, I am quite altruistic, I generally don't like to work for free. Generally people, I'm sure you would work in the Senate totally for free. But it doesn't hurt that they pay.
Yes.
Right?
Yes.
Yeah.
No, thank you for bringing that. That's something that I would not have thought of, not being in the industry. All right, let's talk policy.
Okay.
What is out there? I like to ask people like yourself this question, and I know there are some bills that we're going to speak on and some broad concepts, but from a overarching, you are in the Senate, you are the Speaker of the House, the Senate President, and Governor Baker, all tied in one. You have the ability to press a button and say, we're going to do this henceforth immediately. What would it be?
Well, so the immediate crisis, and you're talking just in the addiction space.
Behavioral health, how about that? Even expand it a little bit to mental health, substance use disorders.
Yeah. So I think writ large, all of the changes that have happened around the ability to do virtual care, I think should be made permanent. The ability to maximize, that maximizes access to both mental health care and addiction-related care. I think, and I'm just talking off the top of my head, the methadone issue that we talked about, working around expanding methadone access, the ability to start methadone virtually, which is still a problem. You still have to have a face-to-face visit
Yeah.
to start methadone. The ability to make permanent the changes in the ability to give folks take homes, the ability to be able to get methadone through pharmacies. There have been a lot of models in other countries and studies, research in this country that have shown that you can give methadone treatment safely to individuals, and that you don't need this really restrictive and frankly oppressive system that we have in this country for doing methadone. So there is a lot that could be done to expand that. I think we need a lot more access to harm reduction supplies.
What is harm reduction
So
for the
harm
viewers?
reduction is the belief that, so we talked about you can't make somebody go to treatment until they're ready, right? And so what you do in the meantime is you want to minimize the harms that they experience. So if somebody's using drugs, you don't want them to get, if they get HIV, that it will give them a life sentence of medication and treatment. So you want to prevent them from doing that. So you want to give them, if they're injecting, you want to give them access to clean syringes and other injection-related equipment. If somebody is continuing to use street sources of opiates, which is all fentanyl now, I think 92% of what's on the street now in the Commonwealth is fentanyl, which is deadly. So you don't want dying is not a consequence that's acceptable, right? We want people to survive, so we want them to have access to naloxone, Narcan. So those are some examples of harm reduction.
John, I don't want to interrupt you, but so are you essentially saying that harm reduction on some levels is about really keeping folks alive until they're ready to make a decision?
Alive and healthy.
Alive and healthy. Okay.
Until they're ready to do something. And in some cases, they may never be ready.
Yeah.
But it's also recognizing the intrinsic dignity of their ability to they're making that decision for themselves. We don't agree, you don't agree with all the decisions that everybody makes, but you do believe in the intrinsic dignity and worth of each human being, and you say, we want to keep them alive, we want to keep them as healthy as possible. So expanding those services, so having, vending machines. A lot of states are now doing vending machines. We could. There are any number of opportunities: mobile treatment, mobile harm reduction. There are any number of things like that we could be doing. And then, a notion that's taken off in other countries, and now Oregon's the first state to decriminalize actually possession. So. To say, we should not be locking up people. You alluded early on to the Good Samaritan laws, and the problem with the Good Samaritan laws, and we've done some research on this, is even though you may not get picked up on the possession charge for that particular overdose, if you have an outstanding warrant, people, and most of the outstanding warrants are for other drug-related offenses. You get picked up, and so people are reluctant to call. So it doesn't really work quite as well.
I am so happy you just said that, Doctor.
It doesn't work as well as we would hope. That's something that could be fixed legislatively. Basically, if somebody calls 911 for an overdose, you get full immunity for that. But also decriminalization is also a statement that people are using. It's out there, and people are going to possess. And arresting people for small time possession, it's not changing the course of their disease, right? But what it is doing is it is making them unable to access housing. It is making them unable to access jobs, pro-social things that we want. We want to make that path easier, right? We want them to go down that path. And a lot of the things we're doing is preventing that. And then more realistic, more closer to where we are is this whole issue of safe consumption facilities. And again, folks consider it controversial, but, the evidence is very clear that it saves lives, it prevents HIV, it reduces syringe litter. Like if people are going to a place to use, they're not dumping their syringes on the street. And the data are also clear that it also gives an opportunity to engage people who are actively use motivational techniques, which we talked about. And many of those folks actually end up going into treatment, going into recovery. It's right now, those folks are out on their own, using on the street without contact, and many of them are dying. So there are opportunities legislatively and from a policy perspective to do things that, and I understand this, these are things that we would never consider, even 15 years ago. But we're at a point in the epidemic where it's not getting better. It's all fentanyl out there, and given the cheap prevalence of fentanyl, it's easy to make. You don't have to ship a huge bundle across the border, or condoms filled with it, mules. It's manufactured in labs, illicit labs. It's not going away. So this problem is with us. So we really need some innovative and, dare I say, fairly radical solution. Radical for us. I mean, in Canada and Australia and
Portugal
and the UK and Portugal and France. I mean, all over the world, countries are doing this and having success. This is one example where American exceptionalism is not helping us.
So me focusing on myself, my trajectory as it relates to safe consumption sites has been, I started off being vehemently opposed to even the conversation. And I was probably guilty of the notion that how are you not just rewarding bad behavior, I think would be the opposition you would hear from many people. I don't want to speak for anybody, but that's opposition that I have heard. And one of the things that I've really come to appreciate, and again, this is an ongoing kind of continuum, if you will, in my evolution of my thoughts on this, is one of the things, and I forget who it was, she said, well, it was Dr. Wakeman, also from Mass General. Dr. Wakeman said, look, she goes, if you look at what safe consumption sites are, push aside for a second the notion that you're kind of creating this space, this environment where people can come and use whatever it may be. What's not being talked about as much is it's also an opportunity, and you just referenced this, Doctor, for you to engage them and say, hey, maybe you ever think about, not doing this, or you ever think about going to treatment? And now I'm kind of putting on my hat, if you will, my political hat, and kind of, because we talk to people all the time, is that I think the debate, the narrative surrounding safe consumption sites we've got to change the lens that we view it. I think it's been a black and white, you're rewarding bad behavior. No, you're not. And I think we kind of got to move to, well, it's really an opportunity to engage these people and to get them treatment. Because one of the interesting things, and I like to say this to people, is that whether it's decriminalization, whether it's safe consumption sites, and I haven't reached a decision on any of them, but what I will tell you is you can just as easily make a very compelling and cogent conservative case for these policies as you could a liberal case for these policies. And in my experience, when you can take both political ideologies and make a compelling case for it, usually that tells you that this could be, we could be onto something.
And my father was a diehard conservative libertarian, and he thought the drug policy in this country was absolutely insane. That People are going to choose. They're going to do what they're going to do, and you should have a right to do with your person what you will, and you're going to make people make bad choices. So you're right. There is a very strong conservative argument to be made for decriminalization, dare I say legalization, and so I'm hoping that we can have a more constructive, as you say, a more constructive conversation about what that might look like, and we look at the data, what other countries, because people have views and ideology and all these kind of things, but what has been the experience of people who've done this? And it's not to say it's going to be a total panacea for all of the problems, but what we're doing now is not working, so I think we need to think about other options.
I think for people in my line of work, I think we have an obligation to it is very easy in my line of work to take the path of least resistance. And a lot of times least resistance in my line of work means what do the polls say on any specific issue? And I have no idea. And this goes for any topic, not even what we're talking about. But I'd like to think that we have an obligation to at least do our due diligence and do a deep dive and say, okay, when we get by this kind of this rhetoric, these broad brushes that people have painted, what would be the actual impact? So in that vein, I know my office, we are taking a trip to Canada to see the safe consumption sites, to see how they're being implemented. Just to, going up there, my obligation is to go up there with an open mind and say, okay, Canada, I forget, okay, folks, show me how this works. How would this work in Massachusetts? And I want to make, when I get asked to vote on this, and I think I will be, I want to make an informed decision. It is unfair for me. I think my obligation goes beyond just saying, no, I think many of my constituents are opposed to this, because if I have a change of heart, and, again, that evolution, which I think, by the way, is a sign of intelligence, not what we would call in the industry a flip-flopper. It's changing the way of thinking. I think I owe it to the people I represent to make an informed decision on any subject, no matter where I land.
Also, when circumstances change, sometimes you have to change your approach. I hate the term flip-flopper, too.
Yeah.
The crisis is worse. People, was it 2,100 people died last year in the Commonwealth?
Yeah.
Almost 97,000 Americans last year died from this, and it's not getting better. 1 million people have died from this overdose crisis. It is not getting better, and if we keep doing what we're doing, we're going to continue. It's more people than have died in all of our wars combined.
Yeah, and it's kind of if it ain't broke, don't fix it. Well, the converse of that is true as well. If it's broke, fix it. I want to, and I just want to be clear here too. I have a lot of friends too. This is an area that I'm really trying to again do that deep dive on, and I think it's really important when having these conversations to kind of distinguish for the simple possession of these substances. In my opinion, anyway, I can't speak for you. It is vastly different from, I think anyway, and how we should treat them, the individuals responsible for disseminating this poison. And I, where I am very compassionate and very understanding and very just wanting to help to someone who's in the throes of addiction, whatever it may be, I am not when it comes to, again, disseminating that poison that's killing a lot of people. And listen, I understand there's a lot of people who are selling to feed an addiction, and it's not simply a black and white, these are the two sides, and there's no overlap. Anybody who thinks that, they're not serious. But the solution to me is kind of, to the extent that we can, really separating, if you will. No, we're not talking about trafficking in fentanyl. We're not talking about possession with intent to distribute fentanyl. We're talking about the simple possession of that for personal consumption, which is far and away different from some of the stuff that we see on TV where there's drug busts and all these other things with large quantities. And again, the reason I brought that up kind of gratuitously is because I think that a lot of times that gets conflated. I hear that, again, back at the grocery store or anywhere else. Just to be very clear, we're talking about a subset of people. And I think that's important because they're, my firm belief is that, folks, again, in the throes of addiction, they're not enjoying what they're doing. Take it from me. They're not. They're miserable. They're miserable. Their very existence is something that they question, again, from my personal experience. So we need to do what we can and provide them the support and everything they can do. You have a bill that we've spoken on. I just want to give you an opportunity to talk about the DCF reporting one. You know what I'm talking about?
Yes,
I just
I
wanted
do.
that. I know that's near and dear to your heart. A dear friend of mine on the House, Sean Garbely, has filed that, and I think there's a lot of merit to this bill. Speak to that, because I think it's important.
Yeah, so currently, Massachusetts is one of the few states remaining that requires people on medications for opiate use disorder or other medications to treat addiction. If you are a pregnant person and you deliver, and that substance, whether it be methadone or buprenorphine in this case, is present in the infant, that is reportable to DCF in Massachusetts. And invariably that leads to an investigation. Now, in many cases it's, but it's very stressful for the parents, for the mother in particular, to have DCF involvement. And these can be people who've been stable and doing well on methadone or buprenorphine for years and years and years, but all of a sudden now DCF is back in your life.
Could be for the first time, right?
And it could be for the first
Yeah.
time. So what a lot of other states do is they sort of the reason this happens is because the feds do mandate reporting numbers of substance exposed infants, but there are ways to do that
Even
without,
if it's medication assisted treatment.
yes,
Huh.
yes, but the thing is, there are ways to do that without having to report to DCF. You can have a separate system for tracking those exposures that doesn't involve DCF. It's totally possible to do that, and that's what most states do. Is they abide by the federal regulation. They give the feds numbers, but they don't take names. And really, that's so. What this bill is advocating for is basically to change this practice, to be more in line with what all our neighboring states. So I'm not sure how many states left in the union do it the way we do it in Massachusetts, but there are none in New England. Every state in New England now separates its reporting from its child welfare apparatus.
To me, it's just, you're reporting to but pushing aside DCF for a second. A lot of times, and we've spent a good amount of time talking about how medication-assisted treatment is the gold standard for opiate use disorders. And if we are to encourage people to engage in that process and to take this medicine, and they're blessed to have a baby, and then the next day they've got DCF knocking at their door or showing up at the hospital asking about it's counterintuitive, because that in and of itself would be a stressor, and stressors are the worst thing for folks who are struggling with this.
We also see people who refuse to go on the medication, who conversely refuse to go on the medication, or they find out they're pregnant, they stop the medication, all because there is just tremendous fear of that involvement, because there are many people who've had involvement in the past and have had other kids with involvement. So it's a complicated issue, but I think this part of it is fairly straightforward, because like many things in policy making, other places have figured it out, we should look to that. We don't need to reinvent this wheel. We should really look to places that have that are doing this in a way that I think is.
Plus, I think a doctor, I mean, we have to trust our physicians and RNs and folks that are involved in the pregnancy, that this isn't saying that if another factor were present, that you couldn't report to DCF if there were evidence of drug use. The problem is that being on medication-assisted treatment, if anything, shows that this person is trying to get better. So it's a counterintuitive result that we have right now. So that's great. Thank you for bringing that up. Doctor, like I said about an hour ago, I could go on hours and hours and hours with you. We've been here for an hour. I can't thank you enough for the time. You already said it, so even if you say no, I'm holding you to it. I want you to come back. This has been a phenomenal conversation. I thought it was anyway.
I would love to come back. Maybe we can do it with call-ins. That would be
great.
Call-ins.
That would be great. And we just got the thumbs up. I would love to do that because, more importantly, no disrespect to my job and the policy side of this. My hope is that somebody in the audience today who's struggling with something that we talked about today says, you want to know what? These are the things that are out there, and this is the course I would recommend. Because in my thought process, if you didn't have an impact on one person, not two, one person's, that's good enough. So, Doctor, thank you for your time. Thank you for the work you do, and looking forward to the next one.
Thank you for having me.